Okay, so first lecture for patho is more of an introduction lecture. A lot of definitions because as we go through how our body responds to injury, when we get to different diseases, we're going to say this causes hypertrophy, this causes atrophy, this causes whatever. These are the things that we're talking about that they're going to cause or the symptoms that they come up with. So these are our objectives for today. The topics we're going to go over as we go through the process. We're going to get into some diseases at the end. Right now, it's more definition stuff with this lecture. So physiology is just normal functions, vital processes of living organisms. Pathology, the study of the functional and structural abnormalities due to diseases. But in pathophysiology, the methods used by the cells to respond to stress and disease. So how does our body respond when something goes wrong? So what kind of adaptations can our cells do? Cells respond to persistent stress. So it's got to be chronic stress or injury or something that's not lethal, but it's constant and it's persistent. Then you'll start causing some changes. When you talk about the response to stress, you have to categorize it. Is it normal or physiologic? Okay, for example, pregnancy. We talked about pregnancy at the last unit in physio. We talked about the adaptation that the mother goes through when she's pregnant. Those are all physiological adaptations. They're normal responses to pregnancy. That's supposed to happen. Then you get adverse or pathologic conditions, okay? Hypertension. When we get to cardio later on, we're talking about hypertension. Hypertension makes your heart very thick. It causes cardiac hypertrophy. But that's not good in the heart. We don't want that. That's a pathological adaptation. Then we can also talk about it as far as is it reversible cell injury? Can the cell recover from this? Asthma, irritation, those are examples of reversible. If you have asthma, you had a flare up for a little bit, but then it goes away. So it's reversible. Other responses, again, this is just definition. So atrophy, cells are getting smaller, they shrink. We have hypertrophy, where the cell size increases. Hyperplasia, increase in total number of cells. So the number of cells goes up. Metaplasia is a conversion of one cell type to another. And then finally, dysplasia, which is disorderly growth. Cells don't make any sense, and you have pictures on the side that kind of describe all that. So again, physiologic versus pathologic. Physiologic changes, increase in size of the uterus. Hypertrophy for muscle growth is a physiologic response to weight training. It's not pathologic, it's a normal response. Pathologic causes, due to an abnormal condition, your thyroid getting bigger due to hyperthyroidism. So the thyroid gets bigger. Increase in breast size in males due to a pituitary adenoma. That causes breast changes in males. That's not a normal response, it's pathologic. Talking about atrophy, cells shrink. Cells reduce their function in response to the injury. What are some causes? Okay, disuse, reduced functional demand. If you ever had a cast on, that arm doesn't work anymore. You're not using the muscles because you have a cast in this place. You're immobilized. When the cast comes off, because of atrophy and you're not using that arm anymore, the muscles get smaller. So atrophy due to disuse. Denervation. Okay, remember, every single muscle needs a nerve attached to it, or the muscle's not going to work. When we learn about ALS, amyotrophic lateral sclerosis later on, ALS is a muscle nerve denervation. The nerve comes off the muscle, so the nerve doesn't touch the muscle anymore, the muscle can't contract, muscle gets smaller. Ischemia, just lack of oxygen, is not going to let the muscle grow, you need blood supply. Nutrient starvation, so anorexia, not eating enough, will cause muscle wasting and atrophy of your muscles. Endocrine issues, persistent cell injury, and aging will also result in atrophy as well. Hypertrophy, increase in cell mass with a change in functional capacity. So result of increased demand. So if you're working out, you're putting the demand on the muscle. The response is to grow hypertrophy to get bigger and thicker. Organ enlargement can also occur. That happens a lot with people who take steroids, the anabolic steroids. Their internal organs get bigger as well, so they get a bigger abdominal cavity, or it gets bigger. This is key right here. The important is that they can't undergo mitotic division, so they can't divide and get more muscle cells, so the muscle cell itself just has to get bigger. So differentiated muscle cells. They just get bigger and thicker, they can't divide. Hyperplasia is an increase in the number of cells. So now these cells can undergo mitotic division, so they start multiplying like crazy. Causes increase in physiologic demand, so EPO and high altitude. We talked about that. O2 drops, we need more red blood cells, more trucks, so EPO comes out. Hormonal stimulation, estrogen. We talk about estrogen, when that comes out in that first half of the menstrual cycle, it makes all the lining grow in the uterus, causes that type of hypertrophy or hyperplasia, and persistent cell injury. Okay, calluses from chronic friction. People work with their hands, weightlifters, they have the calluses all over their hands because of the repeated friction on the bar. If you wear a new pair of shoes that you're not used to, and the back of your ankle gets rubbed in a different spot, it causes a lot of irritation, chronic irritation, it'll cause a blister to form. And eventually, if it keeps irritating the same spot over and over and over, you get a callus formation. So that callus is a hyperplasia. This is gingival hyperplasia. Okay, so certain drugs can cause this. Metaplasia, replacement of one cell type with another, again, due to persistent injury. Reversible when the injury or the offending agent is removed. What's an example of this? Something that people do to themselves that causes cell types to change from one to another. Smoking. Okay? Smoking, repeated chronic injury to the bronchus from repeated smoking, inhalation of the thing. Smoking tobacco, so it irritates the bronchial mucosa, and you get a change in the cell type. Another way, acid reflux, okay, in the esophagus will change the cell type in the esophagus to another cell type, which is resistant to the acid. Remember we talked about in physio how the cells in the stomach are made to resist the high acid, but the esophagus and the duodenum are not. So when you get repeated GERD, acid reflux all the time, eventually over time, those cell types can change into a different type and eventually can even turn to cancer. So here is squamous metaplasia of the cervix. So you can see the squamous metaplasia there, but the covering is columnar. So if you look at the way that this looks, okay, these cells, now look at it, the same border over here. Okay, so there's your metaplasia. Okay. Dysplasia, disorganization of the cells in size, shape, and arrangement within the tissue. Often occurs with hyperplastic squamous epithelium, intestinal mucosa. And again, this is that hole where it can go to cancer, these precancerous cells with the dysplasia. If the entire thickness of the epithelium is involved, then it's called carcinoma in situ or pre-invasive carcinoma. Does not invade the basement membrane. So at this point, the cancer is still localized in the tissue. And I have a picture here that kind of shows what happens. So here's your carcinoma in situ. You still have that basement membrane intact. But now we get invasive cancer, and look at that basement membrane is now gone. I don't know where that pen went. Okay, basement membrane is gone. All those green cells start going out and they start going into circulation. And this is how you get metaplasia or metastases. Because now these cancer cells broke out, where are they going to go into? The bloodstream or the lymph and start traveling around the body and go into different areas. Okay, so that we just talked about what the adaptations to stress the body is going to go under. Now let's talk about irreversible cell injury. You've injured the cells so bad they can't reverse. They're going to have to repair themselves or go away from there. So there's two forms that's going to happen. Either the cells are going to necrose or they're going to undergo apoptosis, which is like a programmed cell death. These are the two things that are going to happen when you have irreversible injury to the body. So we have a viable cell. If it undergoes apoptosis, it just starts getting smaller and smaller, and it just kind of just shrinks. And eventually, all these little cells are then phagocytized and then taken away by the phagocytes. If it undergoes necrosis, it starts getting swollen and starts to leak. And the cells kind of lyse, and all the contents inside break out. So that's necrosis or apoptosis. These are the only two pathways that irreversible cell injury is going to cause. When it comes to necrosis, okay, causes the cells to swell. Rupture and spill the contents into the extracellular space, and this by itself causes inflammation to the area itself. There are 4 types of tissue necrosis, and it really depends on the type of tissue affected. Okay, you can have coagulative necrosis. This is usually caused by anoxia. Usually solid tissue or muscle are going to have this type of necrosis. We can also have liquefactive. This is caused by a pyogenic bacteria, and this usually happens in the brain. And I have some pictures I'll show you in a second. You can have fat necrosis. This is usually due to pancreatic injury. And adipose or pancreas are the 2 likely targets for a fat necrosis. And the last one is a caseous necrosis. This is usually from TB or some sort of fungi, and this usually happens in the lungs. So these are 4 types of necrosis and kind of where they occur. So here is liquefactive necrosis. You can see here how this whole area is losing its color because all the cells inside are starting to dissolve and open all their contents and pour it all out. And you can see here, obviously, there's damage right there, and there's a big hole in the brain where this stuff just turns into like a very soft cheese and just melts away. So that's what liquefactive necrosis is. Here's caseous necrosis. Puts a lot of little holes everywhere, kind of looks like, again, another soft cheese. But this is caseous necrosis, usually caused by TB. So with necrosis, if it happens in a large area, we call it gangrene. So interruption of a blood supply to a large area will cause gangrene to occur. There are different types of gangrene. The first one is a wet gangrene, and this is usually due to a liquefactive necrosis. It can happen to internal organs. It's a very, very bad smell, usually from wounds, burns, traumatic injuries. This has a lot of bacterial growth and infection, therefore there's going to have a lot of pus. This is wet gangrene. It's going to look wet, and I have a picture to show you as well. So there's the wet necrosis, gangrene, and there's also dry gangrene, and this is a coagulative necrosis. So when we talk about coagulation, what are we going to be talking about? What happened to this person? So we're talking about a coagulative necrosis. Clots, blood clots. So remember with gangrene, it's lack of blood supply to a big area. So if you have a clot in an artery, no blood is going to get past that. So therefore, no blood to an area causes ischemia, large area, and they're going to get the necrosis. Here's the key thing with dry necrosis. 1, not associated with an infection. Wet gangrene has an infection, dry gangrene, there's no infection. The other important thing, line of demarcation. When I show you the picture of a wet gangrene versus a dry, you will see in the dry gangrene, they're going to have a very distinct line where it's going to be necrosed tissue, gangrenous tissue, and then normal tissue. The wet one, it just looks macerated all over the place. You're not sure what's going on where. The third type of gangrene is gas gangrene, where they start developing these little bubbles in their tissues. So when you guys are doing your physical exam and you're doing your soft tissue palpation and you're squeezing those muscles as you're going through, if you start hearing popping sounds in certain areas and you think they have an infection, that could be a sign of gas gangrene because you're popping those little gas bubbles, causing crackling sounds, so you may hear some snapping or popping noises as you're doing those things. Again, if they have an infection, not normal people have gas buildup like that. Clostridia is a big one and can develop in your muscles and your organs. That's why I said on your physical exam, when you're palpating those muscles, if you start hearing cracking, popping noises, you check those out. So here's a good summary slide, again, between dry and wet gangrene, comparing, you gotta know this one, obviously. This one's really important as far as the differences between. Now, even though they both have gangrene, one is wet, one is dry, the treatment is the same. Surgical debridement, get rid of all that dead tissue, and if the dead tissue is built up enough, amputation may be required as well. So whether or not they have wet or dry doesn't matter, the treatment is the same. Your job as a clinician is to figure out why do they get gangrene. Was it, if it's a dry or a wet, what happened? What's the underlying cause? Okay, so here's the pictures. You can see wet on the left, macerated, there's no clear line, and on the dry gangrene, you can have that clear line of demarcation right there. This is probably due to lack of blood flow to the area. Okay, no blood supply to the big toe, it dies off. Okay, on the left, wet gangrene, that is an infection. There's pus there that looks wet. This one looks dry. Yes?
How long did it take to get to that point?
I'm not sure how fast that comes on. It's not like in a day or two, but it does happen within a week or two. I think it's faster, but not as like tomorrow. You're not gonna wake up with that. Here's the gas gangrene again, just showing that you have these little gas pockets inside the muscle that can develop, come out of solution. They form a bubble, and you can pop those bubbles. It can also happen on the skin as well. Okay, this is an air bubble full of gas gangrene because of the air that was made from the bacteria. Yes?
So I know you had mentioned blood clots causing gangrene. I just wanted to clarify which one was
Dry. So this is gas gangrene. Again, what it looks like. It looks like blisters, but it's really just gas buildup. So who gets gangrene? What are some predisposing conditions that if someone presents with one of these diagnoses, their percentage, the risk of getting gangrene goes up? Atherosclerosis and diabetes and smoking, peripheral vascular disease. What do all four of those things have in common? What are they all attaching or affecting? What about the blood? Not the blood. Blood vessels. Okay? Diabetes, microvascular complications, atherosclerosis, buildup of plaque inside the artery, making the artery smaller, reducing blood flow. Yes?
I have a question about gas gangrene.
Yeah.
Is the treatment for that the same as wet and dry?
That is more, it's going to be debridement of the dead tissue, but also, again, figuring out the underlying cause. So peripheral vascular disease, smoking, all those things are going to mess up blood flow. They're going to alter blood flow to an area, causing ischemia, anoxia, lack of oxygen to the area. Frostbite, what happens when we get very, very cold? Where does the blood go? To the core. Remember, the body doesn't care about your fingers or your nose or your toes. So they're the first to go with frostbite. But again, lack of circulation because all your blood is being shunted to your core. Your extremities don't have any blood supply, and they can get frostbite. trauma, injuries, and obviously infection. Big one causing the wet gangrene and some of the gas stuff. So that was necrosis, talking about gangrene, the different forms of gangrene. Now we're going to talk about apoptosis, programmed cell death. Okay, they don't rupture, but they get ingested by neighboring cells. The key thing here, no inflammation occurs with apoptosis. With necrosis, because of all the internal contents get dumped out, it causes inflammation and irritation to the surrounding tissues. And if they get weak, then they burst, and then it spreads to the neck tissue and so on and so forth. But in apoptosis, because the cells just get smaller and then they get phagocytized and taken away, and they're fine. There's two pathways which apoptosis is induced. What tells the cell, hey, it's time to shrink and die. We have an extrinsic, which is an environmental pathway, and the intrinsic, which is a cellular pathway. You don't have to go much detail into that, but we have ways to tell our cells that they're survive their use and they're done. So now let's talk about how we can injure our cells. And we'll talk about these things as we go through them. Ischemia and hypoxia. Obviously, it's going to be caused by ischemia. Some damage is reversible after reperfusion. However, with reperfusion, they can cause reperfusion injuries. The way they found this out was we have obviously stents, clot-busting drugs, where if you have a heart attack, you have a stroke, and it's due to a clot, we can give you medicine that's going to break up that clot and restore blood flow to the area. But what they're finding is when you have this clot, the blood that's kind of trapped in that injured area starts going crazy, calcium starts ramping up in concentration, free radicals start forming, inflammation starts forming, and when you open up all the blood supply, some of these products leak out and they start affecting the tissue around it. So what they found was some people can get what's called a reperfusion injury, where you have this localized area of lack of blood flow, you restore it, some people the extent of the injury gets bigger because of this reperfusion injury. So with this reperfusion injury, eventually all ischemic tissue will become necrotic. Okay, when it's ischemic, it dies off, it becomes necrotic tissue because there's no blood supply. When you start putting the blood supply back, it should minimize the damage, but again, what I just talked about, extent of the injury is often increased when blood supply was restored, and they believe it's due to this reperfusion injury. Free radicals, calcium overload, inflammation are the big things. Infectious and immunological causes for cell injury. Viruses, bacteria, prions, all can cause direct or indirect injury to your tissue. Direct injury are usually from endotoxins, enzymes, exotoxins. You're going to learn about in microbiology this fall, all about the different bugs that can cause a lot of problems. You don't need to know all this for now. We'll get to this in a lot more detail when we get to the GI. Talk about diarrhea and stuff. Indirect injury is what your body does to itself when you try and repair and fix the injuries. So either the enzyme itself causes problems, or your body's response to the pathogen can cause you to have problems as well. Nutritional disease. Okay, people don't eat enough. Some are cell type specific. Iron is needed to make RBCs. That's why they tell all women who are menstruating to always take an iron pill right before the period starts, so you build up your iron stores so you can replenish the blood supply faster. Vitamin D in the bone, we talk about that a lot in physio. Others, B12 is needed, vitamin C. When you don't have these deficiencies, vitamin C, that's the scurvy. Like with the pirates, the pirates we get. B12, folate metabolism, and DNA. So if you don't eat the right foods, you don't have the right nutrition, you will have some cell injuries because you don't have the nutrients. Chemical injuries may be direct or indirect again. We have environmental problems, air pollutants, heavy metals. This is where those questions like, what do you do for work, become very important when people come in with certain things. Because we know air pollutants. So if someone's like a cleaner, they're always using chemicals, they're gonna ingest and breathe in some of these pollutants because of the chemicals that they work with. Find out what they do for work. Drugs, Tylenol, methotrexate, alcohol, illicit drugs. Here's your corrosives and your cleaners, toxic gases, carbon monoxide. So again, these are chemical things in the environment that can cause direct or indirect injuries. Physical, mechanical. So here's your frostbite. You see the tips of their fingers are necrosed because of frostbite. This is a electrical burn, I think. No, X-ray. This is a radiation burn on the bottom there. Atmospheric changes, high pressure, low pressure. Okay, people who go scuba diving, you know all about pressure changes. If you come up too fast, you get the bends. Again, it's a physical problem because of atmospheric changes, electrical and radiation burns. So radiation does some weird things when you get exposed to radiation. If you watch Chernobyl on HBO, you saw all about this stuff. Some of the first things that happen, radiation damage really cause a lot of havoc on your DNA. But when you start messing up your DNA, the replication gets off and you start causing some bad cells to form. So what happens is usually over hours, you get cell death starts happening, genomic instability, and again, over weeks to years. That's why a lot of them get cancer, birth defects. Gene pool gets messed up because of the radiation that happened, causing mess ups in their DNA, the way it replicates and causes problems. You have to go into great detail with the radiation, just understand that obviously messes up our DNA. Free radicals can also cause injury. That's when an atom loses an electron. Inflammation can cause free radicals. Ischemic, toxic chemicals, poisons can all cause free radicals. What free radicals do, they attack membrane structure, denature proteins, and cause your DNA to rupture. So that's what free radicals do. And they're also implicated in disease of the joints, heart, kidneys, and lungs, may play a role in the formation of mutations during chemical carcinogenesis. So free radicals are not good. We don't want them. They cause a lot of problems. Any questions about cell changes in response to stress? What all the different things go? Because as we go through them, we're just going to mention that this is what happens, and it's going to refer back to this. Yes?
I'm a little confused on the difference between like the apoptosis and necrosis, because like how would you see that apoptosis is going on? Would there be like holes too?
So the apoptosis, you wouldn't see holes per se, because the cells are being digested naturally. So they just like shrink and just taken away. They're not really causing any, but the necrosis causes like, those tissues are dead, they're dissolving, causing inflammation, and it spreads. So
apoptosis, like an organ would shrink.
it's not really going after organs, it's going just more like just specific tissues, like, or just the cells itself, not the whole organs are going to go away.
Okay.
Yep.
So like cancer is an issue with apoptosis?
I don't think, it's not an issue because, well, yes, you want your body's response should be to program that thing to die. So like we are constantly creating cancer cells all the time, but our body can handle it and take them out through this process, apoptosis. So when it senses like this is an abnormal cell, let's get rid of it, do it that way. Okay, moving on to inflammation. Yes?
For like the chemical causes for direct and indirect injury, is it important for us to know like the examples here with the
No, not for right now. But again, as you get through different classes, they're going to refer back to these type of processes. But they're not going to go into detail about it because we're learning about it here. Okay, moving on to inflammation. Okay, occurs when cells are injured, begins the healing process. Inflammation can be acute or chronic. Some acute responses may be exaggerated or sustained, resulting in tissue damage, septic arthritis. Chronic inflammation may result in scarring and fibrosis. Get in your mind now, whenever you see scarring or fibrosis, that is an abnormal response. And whatever area, mainly going to be your heart, because the heart can't regenerate. It just scars or it's going to fibrose. Whenever you see these words, know that function has been impaired. That function is not going to work. Okay. So what does inflammation do? What's the purpose of inflammation? Neutralize and destroy the offending agent. So if you get a splinter, there's going to be debris. There's going to be pathogens going into your area because of this injury. Limits the spread of the agent. You want to keep it localized to the area of damage. You don't want that infection to spread to other areas. So you talk about a localized infection, that means the infection is just localized to that one area. When you talk about a systemic infection, now that infection spread from an abscess on your finger, now it got into the blood supply, you're going to start getting fevers, more systemic symptoms. The last thing that inflammation does, it prepares the tissue to be repaired. So all those factors that help with healing are all going to come to the area. Again, the goal is to heal that tissue. You got to know this one, these 5 signs. I would know them in the English and the Latin because you'll get them both. Not in this class, but physical diagnosis you'll get a lot in the other classes, but you'll hear both words. So the 5 cardinal signs, and we're going to go through each one of these and figure out why this patient is getting these symptoms for each one of these. So the first one's redness or rubor. You can see it's red. Swelling, it's very swollen. Heat, calor, if you touch this, it would be very warm to touch. Pain, dolor, if you touch it, obviously it would be painful because of the swelling in the tissue in the area. And the last one is loss of function or functiolasa. The loss of function is part of the healing process. If you ever sprained your ankle and you didn't rest it, your ankle would not heal. It would be continuously injured every time you walked on it. So by having loss of function allows the body to heal itself. Okay. So with inflammation, there are 3 events that happen. First one, increased vascular permeability. The second one, we get recruitment of leukocytes. We have to get the neutrophils out of the blood into the tissue to help repair. And the last one is a way to get rid of the offending agents and clear out all the debris. So these are the 3 stages that we're going to talk about. So the first one, vascular permeability. So we get vasoconstriction of the arterioles near the injured site. What is that going to do, the vasoconstriction near the site? What is it? Stop it from spreading. Keeps all the little healing factors in the area. We also have chemical mediators that are released, histamine, prostaglandins, and your leukotrienes. These are all going to cause the inflammatory response. We get vasodilation, increased permeability from the contraction and rounding up of the endothelial cells. We get fluid is pushed out of the vascular space into the interstitial space, and that causes the swelling to occur. So swelling was one of the symptoms. This is why it happens. This increased vascular permeability, fluid goes into the space, into the interstitial space, causing edema to form. And overall blood flow is increased to the area. Again, more blood flow to the area causes the redness to occur because blood's coming to the capillaries in the skin, causing the redness. The heat, because the blood's more closer to the surface area. I have a whole big graph that I'll go through all this, don't worry about writing it now. Here you go. Okay, so that was the first phase. Vascular permeability, more blood flow to the area, vasoconstriction to wall it off. The next thing that happens, we have to get the white blood cells out of the blood into the tissue. So we get margination. So these white blood cells start lining up along the epithelial wall to try and get squeezed out. And they do that, again, increased permeability causes diabetes or diabetes. which is the movement of the white blood cell out of the blood and into this interstitial space. So you see it getting squeezed out there and gets squeezed down into the interstitial space. And you can see here's the bacteria, here's the splinter, the injury that's going on. There's our phagocytosis, eating up all these little debris, cleaning up the area, getting it ready for healing. So that's the second phase. White blood cells start pavementing or emigrating, margination to the wall, endothelial wall, and then diabetes, or the immigration, finally getting it through the wall of the blood into the interstitial space. Finally, last phase, again, neutrophils and monocytes produce enzymes that digest the protein structure. Neutrophils are going to die at the site of inflammation. That's why you get pus forming in an area, because all these white blood cells have died, the neutrophils. That causes the pus. And then finally, the macrophages will come in and they'll clean up all the debris and prepare the site for healing. Okay? So here is the big one that kind of talks about everything. So we got an injurious agent, splinter in the finger, whatever it is, paper cut, whatever it is. Our cells get damaged. When the cells get damaged, they release kinins, histamine, other chemicals, leukotrienes, prostaglandins, histamine are the big ones that come out. So what does this do? The first one, blood vessels start to dilate, which causes increased blood flow to the area, causing the redness and the heat. All of this extra blood flow to the area also brings more nutrients and oxygen to the area, which are needed for healing to occur. You need oxygen, you need nutrients there. The heat that is generated from this infection also increases the metabolic rate of our tissue cells to promote regeneration and healing. Okay? Now, the next thing that happens, capillaries become leaky. So when they become leaky, it causes edema, causing edema fluid in these tissue spaces. You put all this fluid into a joint, it causes pain and it causes swelling. So you're not going to want to use that joint because of the pain. So this causes, again, possible temporary limitation. This is your loss of function. We also get, from all this leaky capillaries, clotting proteins in the area, so we can wall off that area so that it can get repaired. Remember, the platelets come in first, then the clotting proteins come in later. So you need a little bit of time for that to happen. The fibrin barrier gets made, and that helps with the healing process. The last thing that happens, this is the emigration of your neutrophils and monocytes to clear out the area. And again, removes all the dead tissue, the damaged stuff, the pathogens from the area, which is going to promote healing. So as long as you can understand and where the redness, the heat, the pain, the swelling, and the functiolesa, loss of function occur, if you can describe that process, that's where a lot of questions will come from. Make sense? So understand those 5 key clinical manifestations and what the process is that causes them. Okay. I think we have a little bit left, and then we'll take a break. Where are we at? Okay, we'll just do acute and we'll be done. Take a break. So acute inflammation. These are going to become these cytokines, TNF alpha and your interleukins. What do these do? They go to the brain. And what area of the brain are these things going to go to? They have to get through the blood-brain. They can't get through the blood-brain barrier, but we have certain pieces of our brain that are outside the blood-brain barrier that sense these things. It's a big, long word. It has 4 different letters. It's the OVLT of the hypothalamus. It senses all these cytokines, and that helps with fever response. Okay, so brain. When these things go to the brain, raise your body temp. You're gonna get warmer, get a fever, induce sleep, and suppress the appetite. If you ever had the flu real bad, you don't want to eat anything, you got a fever, sleep all the time. Again, it's due to all these little cytokines that cause these havocs in your brain. We get conservation of heat due to vasoconstriction, and we start shaking, causing shaking chills. So we get our, start generating the response of the fever. Remember, we have now changed the set point of our 98.6. Now it's going to be 102. So our body feels colder than what it should be, so we start shivering to warm our body up to whatever our new set point is for the fever. We get stimulation of neutrophils from the bone marrow. Makes sense. We need white blood cells. We have an inflammation going on. We need white blood cells to combat this. We need to get them growing. Skeletal muscle increases protein catabolism. What's going to happen to the muscle? It's going to get smaller or bigger? Smaller. We're getting catabolism. It's breaking it down for its protein to help with the body. Liver, acute phase reactants. These are your inflammatory labs. CRP. You draw that when you want to look at the inflammation in the body. ESR, elevated sedimentation rate, is another marker of inflammation in the body. So we draw these labs. If someone comes in, we want to know, is this inflammatory or is it infectious? Start thinking of that as well with your patients when you start seeing them. Is this an infectious process that they're here for, or is this an inflammatory process? They can be both, but your job is to figure out what's going on with your patient. And then leave us here. We'll take a break. Come back at 11. Okay, we'll get started. Okay, so we talked about acute inflammation. Now we talk a little bit about chronic inflammations where it doesn't go away. Prolonged injury, prolonged infection, specific types of infections, antigens, like an immune reaction. So these are chronic inflammations. So again, a lot of this lecture is just definitions and setting the stage so when you get into your other classes, they're going to talk about this disease causes acute inflammation. Go back to your acute inflammation notes, know what goes on during that. If it says this disease causes chronic inflammation, this is what we're going to learn about now. They get lesions, exudates or transudates. This is just fluid. The difference is where it comes from, which we'll get to in a minute. Chronic inflammation occurs with fibrous repairs or scarring. So it's not going to heal to its normal spot. This is where you get like the callus formation. Just think of that. Chronic inflammation, you're constantly every day grabbing that bar with the sandpaper all over it. It's very, very rough. It'll cause you to have chronic inflammation. So transudates and exudates. What's the difference between the two? A transudate, collection of fluid in a tissue or a space. The accumulation is due to increased hydrostatic pressure. What kind of pressure is that? The push, right? You're on osmotic pressure or the oncotic pressure. Protein, and that's the suck. Okay, remember that stuff. It comes back. Okay. Very watery, low protein content. So an example of this would be what? What would be an example of a transudate? Anyone know? Swelling due to increased hydrostatic pressure. Edema in your legs, okay? Due to CHF, for example. Okay, CHF is a transudate due to increased hydrostatic pressure from all the blood in the veins. Causes swelling in the legs. That's a transudate. An exudate from increased osmotic pressure in the tissues due to the high protein content. So exudates have a lot of protein in there. They're also very localized with these exudates, and we'll go through them in a little bit more detail. So exudates. The first one are called serous exudates, and it has to do with the makeup of the fluid. Small amounts of protein with serous, less degree of damage. These are your blisters. So if you ever get a blister forming, it has all that fluid inside, and you pop it, it's like water essentially. It is a serous exudate, is what you are seeing and experiencing with a blister. You can get fibrinous exudates, large amounts of fibrinogen. This is your scab. Okay, you scratch yourself, you heal, you get a scar from the scab forming. That is a fibrinous exudate. The last one is a purulent exudate or a pus-filled exudate. Okay, these are filled with live and dead leukocytes. So remember I said before, those neutrophils come into the area, but they die in the space of the infection, and they cause the pus to form. There's different types, like an abscess is localized collection of pus. An empyema is pus present in a body cavity, so like you get an empyema in your lungs. It's in the cavity of the lungs, as an example. And then you have a suppurative inflammation, very high purulent exudates, so a lot of pus in these areas. So these are the three different types of exudates and an example of each one. Okay, and these occur with chronic inflammation. Okay, when you start getting into these bottom ones here, this purulent exudate, if someone gets an exudate somewhere in their body, start thinking about cancer. Sometimes cancers cause these weird exudates to form. Just think about cancer in the back of your mind. So with chronic inflammation, there's two things that can happen to it. Either we can regenerate that tissue, or we get fibrous connective tissue repair. That's your scarring, your fibrosis. That's not the good one. We don't want connective tissue repair. So regeneration, most desired outcome. The destroyed tissue is replaced with very similar tissue. So if you're fractured your bone, the bone is going to heal with more bone. So it's a regenerative process. We regenerate the bone with more bone cells. Not all cells are capable of regeneration. Nerve cells and your cardiac cells cannot regenerate. That's why if you get paralyzed, there's not much we can do because it takes a very, very, very long time for these nerves to grow. If at all, they're not going to regenerate back to normal. Cardiac, if you have a heart attack and that tissue is dead, that tissue is going to scar over and it's not going to squeeze as well. If the heart's not going to squeeze as well, what number is going to go down? Ejection fraction. That's how you start looking at damage that a heart attack has done to the heart muscle. You see how much is it still working. Fibrous connective tissue repair, again, it's a scar. Strong bridge across the area, but does not restore original function. So like in the cardiac muscle, it's dead from the ischemic heart attack. It blocked off blood supply. Tissue got ischemic. It died. When it repairs, it's not going to regenerate into a cardiac muscle. It's going to regenerate with a scar, and the heart muscle function is going to reduce. Okay, so that's it on inflammation. This next section is on sepsis. Okay, this is basically how it goes. It's all over the place. Okay, what is sepsis? Life-threatening complication of an infection. Mortality rate is 50% if you have septic shock. 10% of all ICU admissions are due to sepsis. Sepsis is a continuum of physiologic states. So first you get an infection. It's localized. And you have an abscess on your hand, whatever. Then it can become systemic, where those cells get into the bloodstream and start going to the body. So now we have a systemic inflammation. After that, when you're not treating these people and they're still getting worse and worse from this infection, eventually you get hypoperfusion. Okay, what happens to the vessels during an infectious process? Actually, they vasodilate, remember? They get bigger. All the histamine that's being released and the prostaglandins and leukotrienes cause vasodilation. So if there's vasodilation, you get hypoperfusion because the vessels are huge, the pressure drops. If you're not perfusing your tissues, you cause tissue injury. What's the first organ usually going to be very sensitive to lack of blood flow? Kidneys, very good. So you'll see some changes in the kidney function. And then finally, if enough time has gone on with lack of perfusion to the organ will start to fail. So when you start getting end organ failure in a septic patient, that is not a good sign. That means the organ is starting to fail, and not going to work anymore. And it's a body's overwhelming response to an infection. So we normally have a certain response. In sepsis, they have a very heightened response, kind of overboard. Can damage multiple organ systems, leading to organ failure. Must be recognized and treated aggressively and quickly. Sepsis you can't wait on. You got to treat them real fast. Most dangerous to elderly and those with weakened immune systems. So you see this a lot, like who are susceptible to certain things. Usually it's going to be age extremes, very old, very young, or people with immunocompromised, who are immunocompromised. So ICU, people with extensive burns, and anyone with an invasive device. So if you have a catheter in, you have a pacemaker, a trach, something that's even a joint replacement. If you have, let's say you got your knee replaced, and now you start getting septic, and they don't know where the infection is coming from, guess what's coming out? That knee replacement. They take the whole thing out. Your knee they'll leave no bone there. You'll be immobilized. They give you antibiotics to clear out the infection, and then eventually you can get the knee put back in. So anyone with a foreign device, and you have an infection and you don't know where the source is, you have to assume it's the device that's in the body. So risk factors for sepsis, again, extremes of age, cancer history, immunodeficiency, genetic factors, and bacteremia as well. So the stages of sepsis, this one is very important. So the first thing to happen is called SIRS, S-I-R-S. This is the first stage of sepsis, systemic inflammatory response syndrome. In order to be classified as this, you have to have two of the following symptoms: temperature above 101 or less than 96.8, which means you're cold. Okay, very, very cold. Heart rate above 90. Respirations above 20. And the final one is your white blood cell count. Greater than 12,000, which means obviously we're producing a lot more white blood cells because we have an infection. We have to take care of it. Or if you have less than 4,000, that means you can't mount an immune response because you don't have enough white blood cells to do anything. So in the extremes of white blood cells matters too. Too much or too little is a sign of SIRS. And then 10% bands. So this is the first one. They come into the hospital, they have a fever, they're tachy, white blood cells are high, they have a systemic inflammatory response syndrome. It becomes full-blown sepsis when you have a documented culture. So you get your blood cultures done, and you see what infection is, what bacteria is growing or whatever in the blood. Usually you're going to get a sensitivity result as well. So the report will tell you this is the bug that's growing. It's going to be sensitive to this antibiotic, so you know which one to give them. So that's what sepsis is. It's the first column, but now you have a documented infection. You know exactly what bug is causing the problem. The next phase of sepsis is severe sepsis. And now we start getting some end organ damage. Hypotension or hypoperfusion. We're not perfusing our organs anymore. Changes in mental status. Okay, they start getting confused. They don't know where they are. This is a sign of severe sepsis. Now we're starting to get some physiological, from changes in the body. And the last one is oliguria. What's that? What is it? Increase or decrease in urine? Decrease in urine. Why are you decreasing in your urine? Kidneys are not being perfused. If renal blood flow goes down, what happens to your GFR? Goes down as well. Therefore, you're not going to be producing any urine. That's why in every ICU, if you ever start rounding in an ICU, every morning you talk to the nurse, you have to know what the I's and O's are. How much were they intake of water or liquids? How much did they put out of liquid? You have to know how much they're putting out. Lactic acidosis is another sign of infection. Starting to go into anaerobic metabolism, starting to produce a lot of lactic acid. The last phase is septic shock. And basically the patient is unresponsive to fluid replacement. The very most important thing with sepsis, the first line treatment for every septic patient besides getting a blood culture is blasting them with fluids. Giving them tons of fluids because you want to keep that perfusion up. You don't want it to drop, you start getting end organ problems. So blast them with fluids, but some people, they're in septic shock now, they're not responding to fluid. Now you have to give them some other drugs to cause vasoconstriction. Yes?
Is it typically always like a bacterial infection?
I think viral too, just any infection. So that's septic shock. Now you're not responding to fluids. Now you need some more pharmacological support to keep your blood pressure going, some alpha agonist to get that vasoconstriction going, and so forth. So these are the 4 phases or stages of sepsis. Make sure you know each phase and what delineates each phase, what is the key factor. So with sepsis, it's a balance between pro and anti-inflammatory mechanisms are lost. Blood flow to our vital organs become impaired, and clots can start to form. So with some patients with sepsis, they start throwing all these clots everywhere. And you'll start seeing little bits of gangrene pop up in their body. You see little black dots forming. That's not really gangrene per se, but it can in a bigger area because they're throwing all these little clots, all these little tiny little clots get into those small little microvessels, and they block the blood flow past all that, and you get little bits, like little black dots everywhere. In the organs, if a clot goes into an organ, you get organ failure because no blood supply. It's going to die off. So most likely infections to cause pneumonia, cause sepsis, pneumonia, an abdominal infection, UTI, and bacteremia are the 4 most likely ones to cause sepsis. UTIs, you got to be very careful, especially in the elderly. They come in with altered mental status. They think they're having a stroke. It's just a UTI. But you just treat them from there. So here's some, again, start getting used to using these mnemonics, especially getting to the diseases now, to know all the different things. So sepsis, that's just the way to remember the different signs for sepsis. Some common complications of sepsis, disseminated intravascular coagulation. These are all the little tiny little clots that form and go out in the whole body. ARDS, basically they need to be intubated now because they can't support their own breathing anymore. So they need to be intubated for airway support. Acute kidney injury, we talked about that. Kidneys are very susceptible to ischemia, and you'll see your creatinine start to rise, then bun, all that stuff start going up. Hemodynamic compromise, that is your vasodilation causing hypoperfusion. Can't perfuse the tissue anymore, and you get problems. Treatment, again, culture, you don't have to know it for my class, but just because we're talking about sepsis, we'll just talk about it real fast. Cultures, crystalloids are their volume replacement, give them fluids. Antibiotics, and then here's your vasopressors. If they're not responding to fluids anymore and their pressure is dropping, you give norepinephrine, these vasopressors to help bring your pressure back up. Next, we'll talk about immunity. So that's basically everything we had to know about sepsis. Any questions about sepsis? Okay, immunity. Again, just a review from physio. T cells go into the thymus to get matured. B cells stay from the bone, and they come out from the bone, why it's called humoral immunity. Cell mediated because the cell's got to touch. T cells, remember, have to touch the cell. So moving on to humoral immunity. Sounds like a Harry Potter novel, doesn't it? So, Okay, so we have our innate immunity, things we're born with, so our skin, digestive tract, respiratory tract. Internal, our phagocytic cells, interferons, natural killer, and our mast cells. This is our normal innate immunity. We can get acquired immunity, okay, given the antibodies directly or naturally and passively acquired. And then you have your passive immunity. Does not involve the host immune response at all and naturally passively acquired. And this is just another review. I think it's the same picture from physio, so you can review that later. Okay, so immune function alterations. When we're talking about our immune system, there's two things that can happen. Either it can be way too sensitive or not do anything at all. So immune deficiency disease, HIV, AIDS, is a form of an immunodeficiency disease. You can't mount any response to any foreign agents because you are immunocompromised. You don't have the defense. Or you get these hypersensitivity allergic reactions, and I put that in parentheses because the allergic reaction is kind of a misnomer. We'll get to that in a little bit. But now we have too much of a response to antigens. So if you ever eat peanuts, you get a reaction to that. That's what we're going to be talking about in a bit. So hypersensitivity, like I said before, is broader than the term allergy itself. Can include unknown etiologies, and these exaggerated responses may not be antigen to an antibody-mediated response. Autoimmunity, so this is your autoimmune response, are very common, and they help regulate our immune system. So our body knows this is a foreign cell, and this is our cell. We don't want to attack our cells. We want to attack the foreign ones. With alloimmunity, it's disrupted. We get uncontrolled production of autoantibodies, and that leads to an autoimmune disease. So these antibodies don't know that this is your own tissue, and it starts to attack it anyway. That's what an autoimmune response is. So it's essentially a hypersensitivity reaction to the body's own cells. And it can be mediated by lymphocytes or antibodies can do it as well. This is alloimmunity. Okay, an immune system of one person produces an immunological response against tissues of another person. So a transfusion reaction. We talked about blood types, A, B, O, all those different things. If you give the wrong blood type to a person, it causes an agglutination reaction where the cells start to clump up. It's an alloimmunity reaction. Graft versus host disease. This is when someone gets a transplanted organ, but the organ that was transplanted starts making its own white blood cells and attacks the body as being foreign. Usually when a transplant occurs, the body is going to reject the organ as not being part of its body. But in this disease, graft versus host disease, the opposite happens. They get an organ, starts producing white blood cells, but these are specific to the organ that was transplanted, thinks that your body is foreign and starts to attack it. Unfortunately, there's really no treatment for this because now how could you clear out the other person's white blood cells? There's no way of doing that. Unfortunately, those patients don't do well. So what they do is they ablate. Whenever you get a transplant, you have to ablate your immune system. So you take these drugs that pretty much take away all your white blood cells, so you don't make any, because you don't want to attack the new organ that you're getting. So usually before a transplant, we wipe out every bit of immunity that your body can produce, so you kind of start fresh with the new organ. But in these cases, the graft itself, the tissue, starts making its own white blood cells, and it attacks you. Yes?
So would removal of that tissue not help with?
Because it may help the production of more white blood cells, but you already have their white blood cells mixing, and you can't squeeze those out. You can't get rid of those. Okay, hypersensitivity immune responses. So here's the important thing. The patient has already been primed for the hypersensitivity reaction. They've already been exposed to it once. And further contact with that antigen leads to secondary boosting of the immune response. So if anyone here, if you have like a certain allergy and every time you get exposed to it, you get a reaction gets worse every time, it's because your body's already been primed and your body is overreacting to the presence of that pathogen again. Okay, again, it's a altered immune response causing damage to the individual. There is a strong genetic component, so if anyone in your family has certain allergies, you may have them as well. So there are 4 types of hypersensitivity reactions. We're going to go through each one. I want you to keep this mnemonic in mind. A, C, I, D. Type 1 is going to be A, type 2 is B, C, type 3 is I, and then type 4 is D, so acid. These are the 4 ways to classify hypersensitivity reactions. So type 1. Type 1 is IgE mediated. And what's special about IgE? What causes IgE to occur? Allergies. So we call them allergic reactions because type 1 is an allergic reaction. So it is an allergic reaction. There are 2 types, subgroups of this type 1, atopy and anaphylaxis. So when these IgE antibodies come out, it activates and degranulates mast cells. What do mast cells dump out? Histamine. Well, granules, but they're going to be histamine. Okay, histamine. Okay, that causes the leakiness. Remember we talked about histamine reaction in the very beginning of inflammation. And if the histamine comes out and causes these cells to become very leaky. IgE reactions, remember it's A for the allergy for this one, occur between minutes and hours. Okay, so if you know someone has like a peanut allergy or a food allergy, they eat something, within minutes to hours they can feel their throat getting scratchy and whatnot. So it starts to develop pretty fast. May involve the skin causing urticaria, the eyes causing conjunctivitis, nasopharynx, rhinitis or rhinorrhea, asthma, and gastroenteritis. These are some symptoms that you may have as a type 1 hypersensitivity reaction. So atopy refers to a group of diseases: allergic rhinitis, asthma, dermatitis, and allergic gastroenteropathy. So that's what atopy is, and I have a picture for that. It's inherited, triggers pollen, mold spores, dander, dust mites. So your basic allergy stuff. So this is atopic dermatitis. This is eczema, but this is a reaction to something. If you have babies or know around babies, you have to give them like one food at a time, because if you give them too much food at one time and they get this, you don't know what food caused it. So that's why you always introduce foods one at a time to babies to see if anything causes an allergy. The anaphylaxis is the more severe type of this type 1 hypersensitivity reaction. We get systemic anaphylaxis due to all those mast cell mediators getting dumped out. All that histamine getting dumped out causes anaphylaxis. Hypotension or shock, widespread vasodilation, bronchospasm. May get some GI issues. Urticaria or angioedema, what's that? Swelling of the lips and the tongue is angioedema. Can be fatal if the airway is not protected. You're going to have problems breathing. You got to protect that airway. Here's an example of anaphylaxis. This is urticaria, some angioedema in a cutaneous form. Usually if they have this pop up, this is a better prognosis. This is not. Okay, that's severe swelling of the lips and the tongue from an allergic reaction. But it's still a type 1 reaction. Most common causes, your drugs, serum, insect venoms, latex, and obviously your foods. Okay? So these are some causes of anaphylaxis. Signs and symptoms of anaphylaxis: fainting, lightheadedness. Why would they get that? What's going on in all the vessels? Dilating. What's going to happen to the pressure in the brain? It's going to drop. What does your body do when the pressure in the brain drops? You pass out. So that gravity doesn't matter, and blood can go to the brain. Erythemas, redness, angioedema, is the swelling. Laryngeal edema, they can cause some stridor, some breathing problems. Urticaria, asthma, sense of impending doom, like they feel like they're going to die or something. Loss of consciousness, and obviously death is the worst one. Any questions about type 1? Allergy, IgE-mediated atopy, anaphylaxis. Big ones to remember. Type 2, antibody-mediated cytotoxic. This is the C. Why? Because the cells touch in this one. Type 2 is mediated by IgM or IgG. And when they get bound to the antigens, it causes complement cascade to occur. Destroys the host cells by agglutination and phagocytosis. Lysis of the cell membranes happens. So when the cell membrane lyses, all the contents inside come out. RBCs are a very common target for this one. There's your blood transfusion. Causes cells to touch. The antigen and the antibody touch, causing these complexes to form and cause different reactions. So ABO transfusions, Rh hemolytic disease of the newborn. We went over that a lot in physio with regard to Rh factors. Immune system hemolytic anemia. So here's again, child is Rh positive, the mother's Rh negative. Red blood cells may leak across the placenta during delivery. So now the mother is going to start making these anti-Rh antibodies. On the second pregnancy, if that baby is also Rh positive, those antibodies can cross the placenta and kill the baby. So again, cells are touching for type 2. Type 3 is immune complex mediated. This is the I. Immune complexes. So these are complement mediated reactions. Again, antigen to an antibody. What happens here with these type 3 ones is that this new complex starts to embed itself into tissues. It can go into vessel walls. It can go into tissues as well. But wherever these little complexes get stuck and get lodged in the tissue, that's where you're going to have your problems. So when we get to like lupus at the bottom here, SLE, the symptoms of lupus are very, very, very wide. There's a lot of them. But it all depends on where these immune complexes get stuck in the tissues. If these immune complexes get stuck in the kidneys, they're going to have kidney problems due to their lupus. If they get stuck in the heart, they'll have heart problems due to lupus. Depends on where those complexes get stuck. So here's serum sickness. Usually you get antitoxin produced in an animal, so like rabies shot, those things. If you got bit by a snake, the anti-venom they give you can cause problems. Here's your type 4 hypersensitivity reaction. This is T cell mediated, also known as delayed. That's why this one's the D, it's delayed. Okay, this is mediated by T cells, T lymphocytes, and macrophages. Type 1 was IgE, type 2 is IgG and IgM, type 3 was immune complexes, type 4, T cells. So we get antigen deposition, causes activation of the T cells, causes cytokine release, macrophage activation, and inflammation. This peaks a day to 2 days later. That's why it's a delayed response. We have to wait for the white blood cells to get made and form. It takes a couple of days for that to happen. So peak 24 to 48 hours. You've all had to do something for this to get into PA school. PPD test for TB. Okay, you get an injection in your skin, and when do they have to check you? How much hours afterwards? 48 hours. You have to wait for 2 days for this response to occur if you've already been exposed to TB. If you've been exposed to TB and you get a PPD, it's going to pop and be positive because you're causing a type 4 hypersensitivity reaction on the skin because you injected an antigen there. T cells are going to get activated to do something. Allergic contact dermatitis is a very common type. If you ever gotten cheap jewelry and you get a blister forming under the jewelry, that's a type 4 hypersensitivity reaction. Poison ivy, poison oak is a type 4. You touch it today, it doesn't erupt for 2 days later. Those are delayed reactions. So here's some examples. Rust dermatitis, okay? Poison ivy, that might be due to poison ivy as well. So here's your hypersensitivity reaction mnemonics, ACID, puts the whole thing together and gives some examples of what causes those reactions. So this is a good summary slide. Last little bit is just on some selected diseases, and we'll be done with our first lecture. So lupus is the first one. Chronic inflammatory disease, okay? Multiple relapses and remissions, so they get better, then they get worse, and they get better, then they get worse. Can affect virtually every organ system. As I mentioned before, they get type 2 or type 3. They can get a mixture of the two. But remember, these are these immune complexes, antigen-antibody complexes. Wherever they get lodged in the tissue is where they're going to have their effects. That's why no two cases are similar, because we don't know where these complexes are going to get lodged in the tissue. So no two cases are the same because we don't know where they are. And considered an autoimmune, that's why it's the C1, or the type 2, or collagen vascular, so it could be type 2 and type 3 hypersensitivity reactions for lupus. So again, symptoms, there's a whole bunch of them because we don't know where these things are going to get lodged. So that's why they have these relapses and remissions, because they may be fine for a while and then new complexes get inserted into these tissues, and when enough of it happens, then you start getting some symptoms from that. Again, different parts where it is. If it gets in the kidney, there's lupus nephritis. It can get into the joints causing arthritis. So again, all these symptoms are just depending on where they get lodged. So what happens? Excessive helper T cell or defective suppressor T cell induces clones of hyperactive B lymphocytes. What do B lymphocytes make? The antibodies. So now we have a defective process that's making defective antibodies. And what happens is they get autobodies against native tissues. So the antibodies don't know self versus non-self, and it attacks you. Since the immune system does not inherently attack native tissues, this is loss of immune self-tolerance or an autoimmune disease. And native tissues are apparently rendered foreign by exposure to various environmental agents. So usually, when you want to talk to someone about certain responses, Epstein-Barr pops up a lot as an instigating cause for a lot of things. So when you ask about your patient, well, were you sick recently? What'd you have? Oh, I had mono. Okay, well, that could probably cause some things, so on and so forth. So it's these insults that kind of start the process along. They may be fine for a while, but then they get mono or they get Epstein-Barr, and then they start getting sick, and then that triggers this whole lupus cascade to occur as they get older. So the antibodies that have been made, they identify the nuclear and cytoplasmic components. They know what to do. These autoantibodies combine with the antigens against which the antibodies were produced. And you get these immune complexes. Again, antibody, antigen, they combine. And they get trapped in the tissue, and that's what causes the problems. So here's your type 3 reaction. Here's your type 2 reaction. This lupus can have both. The result is the same. These complexes get lodged in the tissue, and they cause damage later on. Okay. Next one is AIDS, so acquired immunodeficiency syndrome. So now their immune response is lacking. There isn't one. Now we're on the opposite end of the spectrum. We're not having a hypersensitivity reaction. We're not having any reaction. It's the most advanced stage. They have HIV first, and then once certain levels drop, then we diagnose them as AIDS. Defect in cell immunity, low CD4 count. So the CD4 to CD8 ratio is a big one when it comes to HIV/AIDS. When it gets to a certain ratio, then they classify you as AIDS. And there's also like 26 conditions that are common in advanced HIV, but rarely occur in normal, healthy people. That's why when people die of AIDS, they don't actually die of AIDS, they die from something else. These opportunistic infections, the 26 infections that don't normally hit healthy people, because they have a very weak immune response, it will cause a problem with their patients. Transmission, infected body fluids, sexual contact, needles, or perinatally. So blood has to be contact. Here's some, if you want to learn more, you can go to the CDC. So acute HIV infection may present with fatigue, pharyngitis, myalgias, rash, lymphadenopathy. Those are all very, very basic complaints that anyone can have. They have the flu coming on. They're going to have those complaints. How do you distinguish if it's the flu or do I need to be worried about HIV/AIDS? Ask. Talk to the patient. Get a medical history. Get a sexual history. You know, have they had any transfusions recently? Do you see how you start asking questions based off of what symptoms they're presenting with? That's why I would ask about those questions. Normally I wouldn't care, but because, hey, they might have HIV, let me ask about sexual history. Are you having sex? Are you protecting yourself? Who are you having sex with? What partners are you having? And the way, if you still are uncomfortable about sexual history questions, just say to every patient, just get this in your vernacular, I ask these questions to all my patients. What is your sexual history? What is your preference? This way it doesn't feel like you're targeting them. You just say, I ask all my patients this question. What do you think? And you ask them those questions. Yes?
If it was transferred prenatally, when would a child start showing symptoms?
It's not a matter of symptoms. It's do they have the virus or not. So when the baby's born, they'll probably draw blood to see what's going on. Or maybe in development, they'll do a amniocentesis and see what's going on. So these are the opportunistic infections. You don't have to know all of them, but like some of them will just make, like oral candidiasis, make sure you know that one. The pneumonias are there. The CNS infections, PNS infections. The cancer is the Kaposi sarcoma, which is what that is. This is a cancer very pathognomonic for HIV/AIDS. Yes? Has to do with your tongue. Yeah. The thrush is oral candidiasis, which is a white plaque everywhere. So all these, again, normal healthy people can deal with all these infections. HIV/AIDS patients cannot. So what is AIDS? It's a lentivirus, means from animals, long-term latency. So the mean time from infection to presentation is about 10 years. So they don't know they have it before they start getting symptoms from it. Because remember, you have to have enough destruction of your helper T cells where you can't mount any type of response. Then you start getting the infections. You have to wait for that number to go down to a point where then it becomes a problem. Very similar to like when we talk about kidney disease. Remember, we have like 500,000 nephrons in each kidney. When you start getting kidney damage, you have to wait till a certain number go away before you start getting symptoms from it. Similar here. Fatal, slowly progressive disease, immunodeficiency, wasting syndromes, and CNS degradation occur. Only infects cells that have a CD4 receptor. Okay, so that's why your helper T cells are targeted with the HIV virus, because they have the CD4, they target those. So loss of the CD4 cells, autoimmune destruction, viral infection and destruction. So the HIV virus will implant its DNA into the host cell. DNA in the host cell starts replicating the HIV virus like crazy. Eventually, you can't hold it anymore. It bursts, and all those new HIV viruses spread, and they go to the next cell, and it repeats the process, and you start getting a full-blown infection. Here's your apoptosis again, trying to kill those, basically killing the T cells and getting them away. Yes?
So the latency, that's for AIDS though, not for
HIV.
right?
Well, no, they'll have HIV, but they won't have any symptoms of it for 10 years.
Of HIV.
Yeah.
Oh, okay.
They may not have any symptoms. That's why people don't know they have it. We recommend regular testing and screening if they're sexually active without protection to make sure they don't have it, because they won't know.
Thank you.
Clinical manifestations: fever, fatigue, unexplained weight loss, lymphadenopathies, LAD. And then again, here are your opportunistic infections. You know, a lot of them are pneumonia. So on their death certificate, it'll say pneumonia. It won't say HIV/AIDS because pneumonia is what killed them. And yeah, we're done now. Okay. We'll start cardio on Wednesday. And then you guys have your ARC meeting at 12:30. It only lasts about an hour. So any question about the schedule or anything?